Welcome to the WebMD Health Discovered podcast. I'm Dr. Neha Pathak, WebMD's Chief Physician Editor for Health and Lifestyle Medicine. Millions of people living with type 2 diabetes have all been told pretty much the same thing. Manage it, slow it down, but we don't really expect it to go away. That's been the story in medicine for decades. But what if the words, "you have type 2 diabetes," didn't have to mean a lifetime of medications, worsening numbers, or a condition that only ever gets harder to manage? What if we use the evidence to write a new story focused on remission? Today, we're going to walk you through exactly what remission means, what it realistically takes to achieve it, and how you can start having this conversation with your healthcare team. We'll talk about the science, the lifestyle changes that actually move the needle, and the honest truth about what this journey to remission looks like. Whether you are just diagnosed or have been living with type 2 diabetes for years, this episode was made for you. First, let me introduce my guest, Dr. Mahima Gulati. Dr. Gulati is a triple board certified physician in endocrinology, internal medicine, and lifestyle medicine. She's an associate professor at the Department of Medicine, Division of Endocrinology, Diabetes, and Metabolism at the University of Connecticut School of Medicine. Welcome to the WebMD Health Discovered podcast, Dr. Gulati.
Thank you so much. It's my honor.
I am so excited to have you because this is such an important conversation. We're going to be talking about diabetes, but more diabetes remission, which I think not enough people know about. So, you've spoken a lot about how much our understanding, specifically about type 2 diabetes, has evolved. Can you share a moment from your career, maybe a patient you treated years ago, or just your experience in practice that shaped how you think today about what's possible with type 2 diabetes, and particularly when you use lifestyle medicine?
Absolutely. So I do remember vividly one of my patients who was a woman of color in her early 40s with mild obesity who developed type 2 diabetes, which was actually mild with an initial diagnostic A1C of 7.2%. She was in tears when I told her that she has developed type 2 diabetes. It kind of progressed from pre-diabetes over several years. And her question to me was, can she get rid of this? Can this ever go away? And back at that time, with the paradigm that we were taught, my answer to her was no. Once she has it, it will never go away. It tends to be a progressive condition. And so now, knowing what I know 18 years down the lane and understanding that type 2 diabetes actually can go in remission with adequately dosed lifestyle therapy, and understanding that it does not need to be a life sentence, that people don't have to live with diabetes once diagnosed, that there are pathways to putting it in remission. And I wish I had known what I know now. So that stands out to me. And over the years, including my training years, I did not get adequate knowledge or understanding or training in lifestyle medicine. And it was only as an independent practitioner, a practicing attending, that I discovered lifestyle medicine. And thereafter, I discovered diabetes remission, and that it actually can be a realistic goal for many patients. Not all patients, but many patients, especially those who have just been diagnosed with type 2 diabetes and they are less than 6 years into their journey. So, with adequate lifestyle interventions, people can put diabetes behind them. And I hope we can talk a little bit more about how to achieve that realistically. But yeah, that story stands out to me about how my personal understanding of type 2 diabetes as a disease has changed over the years, over the decades.
That's really powerful. And I'm so thankful that you shared that story. I want to dig into what you said around remission is possible. Help us understand and define, what does that even mean? What should people expect of the possibility of remission? What does it mean?
We define remission as someone who has previously been diagnosed with type 2 diabetes. And keep in mind, we are talking about type 2 diabetes, which is the more common form of diabetes, which is more than 95% of all diabetes. That hemoglobin A1C, or glycated hemoglobin, is now officially less than 6.5%. So the diagnostic threshold over a period of 3 months without any pharmacotherapy or medications or devices, etc., that are being used specifically for glucose control. And that has to be sustained over a period of 3 months. So that could be based on their hemoglobin A1C, or it could be based off of their kind of an estimated hemoglobin A1C or glucose management indicator on their sensor or continuous glucose monitor. We don't really use fasting glucose here as a remission marker. In fact, now there is also an ICD-10 code, an official diagnostic code for diabetes in remission. So it is very much an achievable target. And we must have discussion with our patients who've been living with type 2 diabetes, particularly those who have recently been diagnosed, to inform them fully about the scope or the natural history of their disease, the progression or the lack of progression, and present them with an entire buffet of options, including and really not underplaying the importance of lifestyle therapy in that buffet.
So let's dig into another thread that you mentioned earlier, which is appropriately dosed intervention. So when we talk about, and I always say this is somewhat of a failing for us in the healthcare profession, where if someone comes into our office and they have a condition or an illness, we are really good at naming a medicine, telling someone the exact dose, telling someone when they should take that dose. But when it comes to lifestyle interventions, oftentimes we give people advice like, you need to eat better, or just get some more sleep, or try to be more active. What do you mean by appropriately dosed lifestyle interventions that you've seen move people from a diagnosis of diabetes to remission?
And that's really a great question. Actually, that's where the meat is at, dosing the lifestyle therapy appropriately and giving it in the appropriate medium. If you look at the United States Preventive Services Task Force definition of intensive lifestyle intervention, or ILI, the definition is 12 or more sessions within a year. And that could be a core or an induction phase where people may have to see their team once every week for the first 2 months, followed by a maintenance phase, which is maybe a little less intensity in terms of the touch points. And whenever I go and I ask my colleagues, whenever I'm doing lectures or talks, I ask them, how many of us have actually seen a patient 12 times in the last 1 year? Nobody raises their hand. Nobody has the luxury of being able to see a single patient and administer lifestyle therapy for 12 to 18 sessions in 1 year, which is what we do research as. So if you look at any lifestyle therapy trial, whether that is Women's Health Initiative or Look Ahead trial, these are built in a format such that a patient has access to their healthcare team, their lifestyle team, at least 12 to 18 times a year. Whereas we don't implement that in clinical practices. Similarly, if you look at the medium in which these lifestyle therapeutic interventions are built into a clinical trial, it will typically involve group visits or group sessions. So patients will come together as a team with their staff or with their healthcare team, and we don't usually do that in clinical practice. So, this to me is very jarring and discordant. How is it that, let's say, if I study the therapy, let's say I had a GLP-1 and I gave it to somebody at a dose of 2.4 milligrams, and I gave it to them as an injection. So, I had a different dose and a different medium in which I administered that therapy. But now, if you look at the lifestyle therapy, which was studied for 18 sessions in a year, in a group format, and I'm trying to translate that therapy, which was studied in that research trial, into clinical practice. But I'm saying, oh, I'm not going to use that dose. I'm not going to use 18 doses in a year. And I'm not even going to use it in the medium of a group. I'm going to do a 20-minute one on one appointment, maybe 2 or 3 times a year. How am I applying that therapy the way it was intended to? So, how am I translating that innovation and actually implementing it clinically? There is a big discordance between what the research shows and how we actually put it into practice when the rubber hits the road.
Yeah, I think it's really important the points that you've made in terms of one, when it comes to medication, we're very, very concrete about the dose that we know is effective and the dose that we give to patients in the real world. And when it comes to lifestyle, it's not necessarily a medication or a procedure, it's the fact that we're seeing people very intensively in the clinic in a group setting many, many times over the course of the year. So 12 to 18 times more. And that's much more than what we actually do. So that's one piece in terms of why we haven't seen so many people even aware about the fact that lifestyle interventions can cause remission because it's just such an intensive intervention. So I'd like to dig in a little bit more to what is happening in those visits. What are you talking about with patients? What are we helping them to do by seeing them so intensively?
It takes effort to actually put diabetes into remission. It takes multiple pillars. We have to intensively change people's diets. Diabetes is diabetes, as we call it. So people have to be given the education on how can they change. It's a seismic change in the way they've been eating and replace some of the foods that may have caused the type 2 diabetes in the first place with more healthful foods. There are patients who may not really eat vegetables or may have never savored the taste. They may not have culinary competencies or skills. They may not have access to fresh fruit and vegetables. So, those are sessions that people should be made aware about and given direct information and education about. Now, keep in mind when we talk about 12 to 18 sessions in the first year, it doesn't have to be with their primary care physician or their endocrinologist, but it has to be somebody who's part of the diabetes remission team who is a lifestyle trained professional, whether they are a nutritionist or a sports physiologist or a sleep medicine practitioner, etc. So they have to create these sessions around their diet, their nutrition, their skills when it comes to stress resiliency or stress coping strategies, their other pillars, including increasing their physical activity, both exercise forms, structured exercise, physical activity, as well as decreasing their sedentariness or sitting time, improving the quality and quantity of their sleep if they are sleep deprived. Also, working on other pillars, especially behavioral and substance addictions. That includes tobacco or recreational drugs or excessive amounts of alcohol, any kind of harmful use of illicit chemicals or behavioral addictions like scrolling on social media, etc. And then, last but most important, how connected they are with their communities, with their families. Do they have social support? Are they lonely? Are they isolated? Do they have access to communities which they thrive in? Because that will become a very big determinant of their overall ability to remit their type 2 diabetes, as we've seen from direct study. And as I told you, it was actually the entire practice that had been randomized. So this was essentially a community format. The entire practice was seen as a model where patients were finding their socialized lifestyle therapy.
So, how do you help people with the overwhelm that can come with feeling like they have to change so much in their lives? What are some of the strategies that you've seen work in your own practice?
We try not to overwhelm, even though, the commitment is intensive, right? We say intensive lifestyle intervention. And we ideally want a significant calorie deficit created in order for people to be able to lose the weight and thereafter lose their diabetes. However, the change is really incremental and small. We do focus on tiny habits or atomic habits, one small shift at a time. We do want marginal improvements to start with and really doing it stepwise. So we have designed lifestyle sessions around one pillar at each visit. We give the patients the ability to see us either every week for at least 6 weeks or every 2 weeks for 3 months to go through at least 6 pillars and then have regular refreshers with our nutritionist and the provider alternating and really have follow up throughout. It's not that once they're in remission, that's it. We do need to bring them back at least once every 3 to 6 months to make sure that the remission stays and that there are no relapses. So the goal is not to overwhelm. The goal is not to go from a diet which is completely ultra processed to something which is extremely clean and organic produce only. The goal is progress, one step at a time. So maybe at least a serving of vegetables a day, maybe 1 cup of green leafies daily, at least 5 days out of 7. And any progress counts. Or having fruit in the morning in place of donut or a refined grain. So we do start with tiny changes and Patients are really good about that messaging when they know that it is about marginal and incremental improvement and progress over perfection.
I'd love to kind of dig in now around the patients that you're most successful with making some of these changes. We know these interventions are more likely to be successful. You mentioned in people who are newly diagnosed, so within the first 6 years. Is there a hemoglobin A1C metric that kind of gives you a sense whether or not lifestyle interventions are going to be helpful? Or have you been surprised? Have you been surprised with, wow, this was an A1C that was so high, I did not anticipate being able to bring this person to remission?
Yes, I have been surprised quite a bit. I have been around now for over 18 years. And so, at least in an isolated clinical practice, I think it's harder to predict if you look at bigger trial data. People who've had diabetes for a relatively fewer number of years, so less than 6 years, may be able to remit their diabetes a little bit more. Not to say that people who've had type 2 diabetes for longer than 10 to 12 years cannot. There are always going to be outliers, but the shorter the duration of type 2 diabetes, the higher the chances, and some of that could be because of the amount of beta cell depletion or the damage done to the total beta cell mass. I offer lifestyle therapy to anybody and everybody who's interested. The biggest marker of success, in my humble opinion, is their motivation, their intrinsic motivation, their drive, more than any A1C, more than their duration of diabetes. It's their hunger to go and learn, their curiosity, their beginner's mindset that determines how far they'll go and how they'll achieve success, not just in their glucose levels, but also other parameters. There are so many other metrics of success beyond their A1C or their sugar or their weight. And so I feel like the determination or the marker really is a person's interest and curiosity and mindset.
I love what you said because I think so often when we're talking to people around medication, we talk to them about other side effects that might happen. Okay, so you might have loose bowel movements or diarrhea or stomach upset. And with these types of interventions, the side effects you get to talk about are you might feel better, your mental health might improve, you might feel stronger, you might get better sleep. So, all of the side effects that you get to talk about when you are starting this intervention are generally positive side effects, which is always such a pleasure to have that kind of conversation in the clinic. We're learning so much more about this dance, this interplay between fat cells, between where fat sits in your body, how much skeletal muscle you have. All of that plays a role as well. Can you give us just a brief primer on some of these other factors besides just insulin?
This was something that drove our understanding of remission of diabetes. In fact, Roy Taylor and his colleagues who did some of the seminal research on diabetes remission hypothesized about something called the twin cycle. It was initially a hypothesis, then a theory, where the kind of the conjecture was that if somebody is in positive calorie balance, as in they are eating more calories than their body's requirement is, that extra calorie balance essentially gets stored in their body as excessive lipid in their adipose tissue, their subcutaneous adipose tissue. But there comes a point where they reach a fat threshold, a PFT or a personal fat threshold, where their subcutaneous adipose tissue can no longer hold that excess lipid. So now this lipid becomes available to store in other sites other than subcutaneous fat tissue. And that's called ectopic lipid or ectopic fat. So this excessive lipid spillover then occurs in the viscera, the so-called visceral fat, which is considered the dangerous fat. And that's the around our trunk organs, so our central abdominal organs, particularly in the liver or hepatic steatosis, also called popularly fatty liver. So this is where it starts depositing topically. And then the spillover can also go to other organs, including the skeletal muscle, the muscle compartment where it does not belong, or the pancreatic islet beta cells. And when we have all these surplus lipid particles, and these are diacylglycerols and ceramides, these are toxic to those organs. So when beta cells start accumulating so much liposity, that causes stress, lipotoxicity, in their endoplasmic reticulum. So the beta cells cannot produce insulin the way they were because of excessive lipids. And there comes a point where the insulin production can no longer catch up with the amount of glucose in the circulation. But there are other players. There's the brain, there is the role of the kidney. And it's a very, like you said, it's a very sophisticated dance. At the center of it, though, is long term positive calorie balance, which comes, we know now, we know that this is caused by ultra processed food and obesogenic environment and other exposures. It could be caused by toxic exposures in the environment, endocrine disrupting chemicals. It could be caused by lack of physical activity, lack of sleep, etc. So, all of these insults accumulated over years and years can contribute to positive calorie balance, where people are eating consistently like 200 to 500 calories more a day than their body can process. And over time results in beta cell injury, leading to overt manifestation of diabetes.
I am so thankful that you mentioned environmental causes. You mentioned ultra processed foods, which really, if we get down to it, are meant to be addictive. There are so many things in terms of what food scientists that work for these companies do to make us want to eat more of these types of foods. Because I think it's really important for people to realize that it's not necessarily a question of willpower or that there is something that you're not doing right if you're gaining weight, because there are so many external factors that may be beyond your control. And I think the beauty of lifestyle medicine, especially how you're explaining it, is that these are some factors that we can identify that we can work together to adjust, to improve, so that we have an ability to then take something that may have been out of our control and bring it to a level where we can now be considered in remission from diabetes. And along with that, have all of these other positive benefits in our life.
We do know from multiple studies and work of scientists like Ashley Gerhardt, who's talked about food addiction. She developed something called Yale Food Addiction Scale and talks about the features of ultra processed foods in terms of their craveability, people's sort of withdrawal if they did not have that food, etc. So in some ways, it kind of matches addiction to any other substance, right? And then there is obviously the work of Carlos Montero, the creator of the Nova food classification system, where they mention how basically the industry has created this entirely new class of foods, which are directly replacing the class one foods or the unprocessed foods. So, soda is supposed to or created to replace water. If people are going to have soda with their meal, it's highly unlikely they're also going to have water. Or if somebody is going to have a McDonald's burger, it's highly unlikely that they're also going to have homemade beans too, right? So, these are directly competing against unprocessed foods. And there are engineered ways in which these foods are created to be hyperpalatable and consumed in a way that drives more consumption. So there are actually interventional studies that show the amount of overconsumption that's driven by ultra processed foods, which is not the case with unprocessed foods like apple or broccoli.
I'd like to now spend some time talking about work that you're doing right now with Project Remission, which is a lifestyle medicine approach to type 2 diabetes and really trying to get the word out there. Number one, I think, in my view, but I'd love to hear yours, is to help people, health professionals, and patients recognize that remission is possible and it's a conversation that needs to happen. Can you talk to us a little bit about why you're doing this work?
Absolutely. So, Project Remission is a multi stakeholder collaborative effort spearheaded by the American College of Lifestyle Medicine. We're essentially putting out a toolkit for all professionals involved in the care of type 2 diabetes. It's a all hands on deck approach. So, for communities, for health systems, for independent practitioners, for trainees, anybody who is involved in any aspect of healthcare. And there are resources, videos, social media kits, etc., available for people to educate themselves and look at how can they fit this into their practice, into their daily lives. I think we have to flood the zone with the right information. The only way we can counter misinformation and disinformation is by putting adequate evidence based scientific information, which is implementable. Like I said, we have had innovation now for years and years, more than decades, but we need to give people scalable, sustainable solutions that they can start implementing today.
I'd love to understand a little bit more about what patients should expect in terms of having a conversation about remission with their providers. Number one, how should they bring this up if their doctor is not talking about it with them? What should they say? How can they start that conversation?
So, for the patients, they want to have a trustworthy provider or a healthcare professional team that knows what they are doing. If your provider is unaware of the remission data, maybe start with bringing them resources, for instance, from Project Remission. There are short videos that you can show your provider in that appointment and tell them that this is what you want to aim for. And hopefully, they're going to want to do that journey with you where they can set you up with resources in your community and in your health system so that you have access to the right nutritionist or the right physical therapy team. So, that would be it if you want to educate your healthcare team. You want to tell them what your goals are. And if they already know about that, if you go to somebody who's a lifestyle medicine trained professional, then hopefully they've already created an infrastructure where they can plug you in with the type of resources, whether that's a group visit or an intensive lifestyle clinic, and you can get started effortlessly on that journey because you will need support. It takes a village. And you want to get the right information along the way. You want to be supported on your goals. If it's sleep that you're struggling with, you want to go to the right sleep lab or practitioner who can understand what's causing lack of adequate sleep or lack of good quality sleep, etc., for instance, right? I think that would be the place to go from to bring them the right material if they don't know. Or if they already know, then hopefully you'll have all the support you need.
And I'd love to also kind of get a little into expectation setting around setting a goal for remission. What does that mean with regards to how frequently you should have your A1C checked? So, in my practice, if I'm managing someone with diabetes that has been relatively stable, I may not, because of health insurance reasons, be able to check an A1C more than 2, 3 times a year. Help us understand what follow up labs and follow up with regard to monitoring looks like.
Absolutely. So, if their goal is diabetes remission and they are really intensively changing their lifestyle 180 degrees, going from really ultra processed diet to a very, very highly minimally unprocessed diet, right? So, they will only be able to get their A1C in 3 months because it's a 3 month average, and most insurances will not cover it before 3 months. But they can check their glucose every morning. And in fact, the glucose drops if there has been a significant calorie deficit created. The fasting glucose can drop sharply. We are talking about going from more than 180 fasting glucose to something which is in the range of 100s within 7 to 14 days. They could wear a continuous glucose monitor, which is covered by many insurances, not all, but many. And that can give them a rolling 7 to 14 day A1C or a glucose management indicator. And then there's something called time in range where they can check how frequently during the day they are in a good glucose range, which is 70 to 180 milligrams per deciliter. So they want that green range, the time in range to be as close to 100% as possible. They're not hopefully going above 180 at any time. And that can happen rapidly. It can take time, don't get me wrong. So it's sometimes if they've been at a 250, it can take a while for that number to go down, especially if they are making small incremental changes. But as long as there is movement or progress, like I said, that can be a very encouraging and empowering format. So, monitoring what gets measured gets managed. So, if they're measuring their glucose and they are really looking at it daily, that can help spur most of them, although there are people who can get discouraged. So, if that doesn't work for them, then maybe they should check in with their team once a month to see where their glucose numbers are at. That would be the format.
That's great. And then can you talk a little bit about the importance of doing this with a team and a healthcare provider because there may be medication adjustments that need to happen and you don't necessarily want to do this in a way that's completely on your own because if you're taking medicines on top of it, your sugars can drop really significantly.
Absolutely. Especially if they have quite a few medications for their diabetes. So if someone got diagnosed with type 2 diabetes and they've not yet started a medication and they want to do a lifestyle journey, they may be better off in that sense that they don't have to worry about titrating medications down. Although, if they have medications for high blood pressure or maybe other comorbidities like high cholesterol, maybe they may need adjustments for that, especially if they've lost a lot of weight, they may no longer need a high dose blood pressure medication. So definitely having frequent touch points with your healthcare team, whether that's a clinical pharmacist or your physician or your other providers, is really key. So yeah, definitely patients should pay attention if they're on multiple medications and how to adjust them down. This is called deprescribing. It can be particularly important if somebody's already on 3 or 4 different diabetes medications, including the ones that can cause a low glucose or hypoglycemia. Especially if they're taking insulin, they may need to rapidly, like really sharply, decrease their insulin dosing.
That's really helpful. As we're coming to a close with our conversation, I'd love to also honor just some of the feelings of hope that might be, emerging for folks as they hear about the possibility of remission, but also feelings of fear that, what if this is not possible for me, or shame if you're able to bring it down and then things bounce around. Talk to us a little bit about your experience with patients. Again, to your point of it's progress, not perfection. So talk to us a little bit about those pieces as well.
Yeah. And this is where it's a journey, not a destination. There is no failure. We can remit, we can have a relapse. There are difficult seasons in life. And it's the job of a good healthcare team to always give hope, no matter where you are in your journey, to always empower, to never take away the hope or the agency, to really sit and bear witness to a person's suffering through their different seasons, right? So I think it takes knowing, getting used to your patient, really being with them longitudinally, understanding their intrinsic motivations, what's the place of fear, and holding their hand as they go through that journey. You may not be able to solve their problems, but really bearing witness and sitting with them and listening to their fears. And then maybe if you need to, you can refer them to the right professional because you may not have all the answers. Not everybody is going to have remission. Not everybody may even want remission. That may not be their goal. So you have to have that shared decision making pathway, but also offer them that hope through not just your words or your processes that you've created in the clinic, but through other means, including being present.
I love that. I think that nothing can take the place of just holding your patient's hand and letting them know that you're there for them in the ups of the journey, but also the downs. I'd love to end our time together by giving you the floor. Any last bits of information you want to give about Project Remission or advice about getting started on a journey towards a remission, if that's your goal?
I would say please spread the word. Please familiarize yourself, educate yourself. And through that, educate your immediate circles. We all have our circle of influence. I am now better as a physician, as a mother, as a professional, as a teacher, just knowing about remission and having that power. I'm more empowered. And since I'm empowered, I can empower more patients. Find out as much as you can, be curious, and inform your providers, inform your healthcare teams. And yeah, it doesn't take a lot to make it a movement and create a new standard of care.
That's beautiful. Beautifully said. I want to thank you so much for your time.
Thank you so much, Dr. Pathak. It was a joy.
I'd like to share 3 key takeaways from our discussion. First, type 2 diabetes does not have to be a life sentence. The biggest thing I want you to walk away with today is this. If you or someone you love has been diagnosed with type 2 diabetes or even prediabetes, remission is a real and achievable goal. Remission is especially possible if you've been diagnosed within the last 6 years. But as Dr. Gulati mentions, anyone is a good candidate. Second, the dose of lifestyle medicine matters. We heard today that lifestyle therapy works, but only when it's given at the right dose. That means working with a team to address proper diet, sleep, stress, physical activity, and social support. Small incremental changes can add up to something transformational. You don't have to overhaul your life overnight, but slowly you'll find as you make progress towards your lifestyle medicine goals, getting to the right dose can lead to transformational change. The goal, though, is progress, not perfection. And finally, be your own best advocate and bring the remission conversation to your doctor. If your doctor hasn't mentioned remission yet, that's okay, because now you know to bring it up. Resources like Project Remission from the American College of Lifestyle Medicine offer free toolkits, short videos, and educational materials you can literally hand to your provider at your next appointment. And also, don't forget to ask about a lifestyle medicine referral. Your curiosity and your motivation are the most powerful predictors of success on this journey. With the right team, the right tools, and one small step at a time, remission is not just possible, it's within reach. To find out more information about Dr. Gulati's work and the Diabetes Remission Project, make sure to check out our show notes. Thank you so much for listening. Please take a moment to follow, rate, and review this podcast on your favorite listening platform. If you'd like to send me an email about topics you're interested in or questions for future guests, please send me a note at webmdpodcast@webmd.net. This is Dr. Neha Pathak for the WebMD Health Discovered podcast.